The bubble that doesn't travel. This is about a patient who was operated for an RD surgery 4 months back, and he developed a nuclear sclerosis grade 1 to 2. Patient has nystagmus and he's come up for a surgery. We've gone ahead with the routine topical surgery, and we were operating on ingenuity. And during the hydrodissection, we realized that there is a rent which has happened. So we have a rent, and we've noticed that before starting the phacoemulsification. We've gently done the hydrodelineation, and we proceed with phaco using slow-mo settings of a IOP of 26, a maximum vacuum of 450, an aspiration rate of 26, oozle 60% with IP on the centurion. With the slow-mo phaco, we did not find any problem during the phacoemulsification, and in fact, it went on pretty smoothly. It seemed as if there is no rent at all. So thinking probably that there is no rent, I just came out, and there you see we have a nice big rent, and the silicone has entered into the chamber. The moment we form the chamber, we are able to remove off some part of the silicone bubble. But what we realized was the more we press, the more the oil comes out. So what we did was we cut off the oil because it's like a dumbbell. So you remove it at the attachment part where the pedicle is, and the oil settles down back inside the chamber. The rent, for some reason, does not extend, and it remains at that because probably it could be an inadvertent lens touch by the retinal surgeon, which has made that area to be a deficient area or a weak area which ruptured during the hydrodissection. But interestingly, the edges were a bit strong, so they did not go and tear off, run off into the periphery. So those high viscosity silicone oil floating on the conjunctival cul-de-sac. The moment you put viscoat in the chamber, that also is good enough to tamponade the silicone oil. So once the cortical aspiration is done, we proceed to put the IOL. Here the choice of IOL would be a 3-piece IOL, and I would try to put it inside the bag as well. The rexus is intact, so definitely I'm going to try to put it in the bag, and I am able to do it with a bimanual maneuver. So that's the leading haptic going inside the bag, and then you dial the rest of the lens in the bag slowly. The silicone oil does come out a bit, and you can actually tamponade it back again. And whatever excess oil bubble is remaining in the chamber, you can safely remove it. So the optic is now tamponading the entire silicone oil behind the posterior capsule and is not allowing that silicone oil to come forward. And once that is done, you form the chamber, hydrate the wounds, and finish the surgery. What we learn out here is, unlike the vitreous, which actually, if allowed to, tries to engulf the nucleus and causes a nucleus drop. The silicone oil here, which is a high viscosity silicone oil, actually allows, it pushes the nucleus ahead. So it's never going to allow the nucleus to drop down. This is on the same day as the surgery, you can see the length, and this is after 3 days. Thank you.